Welcome, everybody. Thank you all for coming. For those who I don't know, I'm Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health. This is our monthly public health forum where we invite leading scholars from all over the world to talk about issues that are at the cutting edge of the scholarship of population health science. Before I introduce today's speaker, I would like to introduce a special group of guests we have with us today. Those are our community scholars. So very briefly, let me tell you about the community scholars, then I'm going to ask them to stand up for a round of applause. So our community scholars program started at the school in 2000. It was launched by my predecessor, Dean Bob Meenan, and really emerged from the school's history as being an active partner with urban communities. Community scholars are public health professionals who receive half-tuition scholarships, pursue an MPH degree here with us at the School of Public Health while continuing their work. They are employed in government, academic environments, health delivery, for-profit, not-for-profit agencies and organizations, and they bring to our community a real infusion of life in the real world combined with the academic work in which they engage. We feel that everybody benefits from the Community Scholars Program. The students benefit because they get financial resources supporting their education. Their agencies benefit having employees who are getting the skills and knowledge to address real-world public health challenges, and we benefit tremendously by hosting smart, committed, experienced students. It's been 16 years since the program started. The program has helped support about 160 scholars, 23 of whom are currently getting their MPH degree. And we are delighted that many of our scholars and many of our alumni are with us today as guests. We thought we would invite the scholars here to honor them briefly on today's forum because addressing transforming public health curricula towards improved population health seems to resonate very much with some of the themes that our scholars engage in. We feel that our scholars, past and present, help us understand the educational and training needs of the public health workforce because they are very much doing the work of improving population health. So today, on behalf of the entire School of Public Health community, I wanted to acknowledge and celebrate the professional, academic efforts and achievements of our community scholars, past and present. It's my hope that they will continue sharing their knowledge and experiences with us as part of the SPH community. We are extraordinarily proud to host all the scholars. If I can ask the scholars to stand up. Thank you. Thank you all for being with us, and we shall have our reception after Dr. Petersen's talk, in part honoring the scholars. So I'm going to move on now to introduce Dr. Donna Petersen. We are really thrilled Dr. Petersen is here with us. One of the goals of the Public Health Forum is to really invite thought leaders in public health from all over the world to spend time with us. One of the challenges is that these thought leaders are very busy. So it's really, we consider it our good fortune that people like Dr. Petersen have agreed to spend the day with us. Thank you. Dr. Petersen is Dean of the College of Public Health, University of South Florida. Before that, she was professor in departments of maternal and child health and healthcare organization and policy at University of Alabama, Birmingham School of Public Health. Before that, she was also Senior Associate Dean for Academic Affairs at UAB, and before that, she served as Director of the Division of Family Health at the Minnesota Department of Health. Dr. Petersen has an extraordinarily distinguished and long bio sketch, which I will not summarize here fully, but suffice to say that she is one of the few people who is, I think, navigated successfully at the highest levels, working in public health practice as well as in the academy. She is an expert in maternal child health, healthcare reform, systems change, and leadership, and she has written all sorts of papers, published in all the right journals and all that, which I won't get into. At the level of the deans and deans engagement, Dr. Petersen has been a national and global leader in thinking about public health and public health education. And she has, from my perspective, been probably the singular dean who has been the clearest in articulating where our public health education should go. And I was very excited when she chose for her topic, Framing the Future, Transforming Public Health Curricula Towards Improved Population Health. Donna.
Thank you, Dean Galea, and welcome, faculty and community scholars and friends. Can you hear me? Am I on? Am I on? That's great. Okay. So I am truly honored to be here. I am always appreciative of an opportunity to talk about these things that are very near and dear to my heart. And because the theme of your Public Health Forum this year is on population health, and because I've been traveling around the world now talking about framing the future, I thought, well, I can combine those two and we can have a fun conversation. So what I want to do is want to spend a few moments just sort of giving you a little bit of the background of the initiative and where it came from and kind of where it ended up and where it's going, and try to do that as clearly as I can in an objective manner, even though I lived through it all. But then I want to apply a different lens to it. And it's not the lens that we carried out the work using, but in reflecting on this talk, I realized it's a lens we could have used. And so I'm going to sort of reframe what we did through that lens, talk a little bit about what I think that might mean, and then hopefully engage in some conversation with you. And I understand that my remarks are between you and me having a conversation and you and me going to the bar. So I'm going to talk as quickly as I can because I appreciate that it's a beautiful afternoon. I know you say, oh, she's from Florida, she hates this weather. I'm actually delighted to feel some cool air, so thank you. So I want to take you back to where this initiative started. And if you can remember where you were in 2011, that's almost 5 years ago now. What was then ASPH, the Association of Schools of Public Health, now the Association of Schools and Programs of Public Health, so even that has changed in the time frame that we've done this. ASPH had released the undergraduate learning outcomes report, which I'm going to talk a little bit more about later, but it really sort of set the stage for what we decided to do next. So here we were, it was July in 2011, we were in Montreal at the Dean's Retreat, and I had just agreed to chair the Education Committee. And we had a lot of potential opportunities on our plate. So we had just released the undergraduate learning outcomes, and there was a lot of interest on the part of the then growing undergraduate community to say, well, you're the Association of Schools of Public Health, tell us what our undergraduate degree should look like. What should they cover? What should the content be? So we had that. The MPH competencies, if you remember those, the original set, had been written in 2006. And if you are a competency guru, you know that you're supposed to review them every 3 to 5 years. So they were getting old. We had recently completed, we being ASPH, the DRPH competencies, but there was tension when that document was written, and there continued to be tension in the field about were we in fact making a clear enough distinction between the PhD and the DRPH, so that was still kind of out there. The Interprofessional Education Consortium had just released its first set of competencies around IPE, so that had just happened. The Lancet Commission on Global Professions, Health Professions Education, that report had just been released, which really argued for a deeper effort around interprofessional education for a global world. The Affordable Care Act was a year old at this point, kind of hard to believe, and this was before any of the Supreme Court work had happened. And part of the Affordable Care Act, and this was something that we were actually talking about as deans, the hospitals around us, the nonprofit hospitals around us, per the Affordable Care Act and changes in the IRS tax code, they had to do community needs assessments, if you recall this. Right now we think about, but this was all happening at this point in time. So there was a lot happening. And we were sitting in this meeting and kind of, we were overwhelmed by the work that needed to be done, the number of opportunities, how were we going to do this work? We were one committee with great staff, but we were all busy people with full-time jobs, and what should happen first? And I credit my friend Barb Reimer, who's dean at the Chapel Hill School of Public Health, the University of North Carolina. She said, why don't we take a deep breath and take a step back? And let's take an empty room approach. And that was her phrase, and so I always show this slide. She said, let's take an empty room approach. Let's pretend we don't know anything. Let's pretend there's no public health education, there's no public health schools, there's no degree programs, and let's plant ourselves today and let's look ahead and say, what would we have if we could develop it now, fresh? So, because timing is everything, that was 2011, and because you're all good public health history students, you know that in 1915, the Welsh Rose report was written. Honestly, show of hands, who has read the Welsh Rose report in this room? Your dean, Dean Galeo, thank you. He has read the Welsh Rose report. It's not very long, and it's actually an interesting read, and you can find it on the Delta Omega National Public Health Honorary website. I urge you to look at it. But that was written almost 100 years ago at this point, right? So we said, wow. So it's not only that we should take a fresh look because things are changing around us, but because it's almost been 100 years since somebody wrote the blueprint for schools. So 2015 was 4 years away. We said, can we do this? And we said, yes, we can. But let me take you back a little bit over that 100 years. So again, you can see how much has changed because we weren't strict adherents to the Welsh Rose report. It did lay the groundwork, but things had changed in the 100 years since the Welsh Rose report. So the first thing that changed was Welsh Rose in 1915 recommended institutes of hygiene, that's actually what they suggested, in schools of public health, to train people and to confer the Master of Public Health and the DRPH. So they both wanted a degree to prepare professionals, but they also wanted a degree to do the science, the research, the hygiene, if you will, to inform the growing profession of the field. That's what Welsh Rose said. So we go from an MPH and a DRPH to now, depending on where you are, what school, what program, what institution, you may or may not be offering some combination or all of these degrees, from different doctoral degrees, different master's degrees, undergraduate degrees, even two-year degrees, all kinds of joint and dual degrees. I didn't list them all here, but you get the point. The other thing that Welsh Rose said was that these institutes of hygiene should be training people with MD degrees primarily, though they allowed for other clinically prepared professionals, but that was the target student audience. And again, over time, we see a dramatic shift and growth in the types of students that we attract. And again, if you think about that array of degree offerings, it's not a surprise that we are recruiting people directly out of high school into two-year programs or into our undergrad programs, from undergrad in our programs, from other degrees into our program, right? They come from all over the place. 1915, Welsh Rose said the primary purpose of this MPH degree is to prepare health officers for what was then the growing field of public health in the states and in communities across the country. So in 1915, there were still states that didn't have state health departments. So part of this, and you had counties, and people were starting to create health departments, understanding the science was growing, and they understood they needed somebody to sort of coordinate public health efforts. So this all kind of tied in. So we were giving the MPH and the DRPH to physicians so that they could be health officers and conduct the science to inform the health officer's role. Okay? And today we know our graduates go anywhere and everywhere, to the private sector, to the nonprofit sector, here domestically and around the world. And you also, if you have been around for a while, you know that ASPH was heavily invested in developing a set of competencies. This came from several of the IOM reports and other public health practice academic partnership efforts, and we were really trying to make sure that we could articulate what we thought professionals needed to know and be able to do in their fields. And again, the education committee looked at all of this and said we really need to take a fresh look. So the Framing the Future Task Force, that's what we chose to call it. We actually came up with the outline of it and the structure of it at that July meeting. We formed it in the fall. We actually started, I was going back through older slides. I'm trying to remember, I think the initial group was 24, 25 people, was the initial group. And over time, as people heard about it, or we thought about people we hadn't thought about, people would ask if they could join, and we always said yes, because there was no reason to say no. So we ended up with more than twice that, and it was a very, very diverse group. Of course, academic, the schools and the programs were there, but so were our practice partners, so were other health professionals, the folks from CDC, from HRSA, from the Robert Wood Johnson Foundation, from the Legacy Foundation. I mean, we had a nice mix of people. Later on, when we started thinking more about where do our graduates go, because when you're rethinking what curricula should look like, you have to think about for what purpose. And to add every possible employer group that we could think of, the task force would have been completely overrun, and we just didn't have room for that. So we created an employer advisory panel. They never met, but they agreed to serve. We interviewed each of them in depth, and then they reviewed every report that was produced, and they gave us comments. And so in that way, we were trying to, honor the spirit of trying to prepare people for the various career paths that they might pursue. The charge was simple: reconsider the role of public health education 100 years post Welsh Rose and set a vision for the future. And in parentheses, I put here, because I quickly discovered as I started traveling around the country, that we weren't the first to think of these things. Other people were having the same thoughts, and people were already moving to transform what they were doing. And so early on, we sort of took this approach of That's great. We want people to transform as they wish to, and we're not going to make anybody wait or suggest anybody wait. We're not going to do this in a secret way, and you have to wait for the report to be issued. We're going to really encourage transformation as it's happening, which is really kind of fun. We agreed early on to tackle all of this if we could. What's not on this list, because it wasn't on the initial charge, we actually spent a lot of time talking about K-12, which, if you want to talk more about later, I'd be happy to, because that poses a whole nother set of interesting opportunities and perhaps some challenges. But we said we needed to look at the undergrad world. We needed to rethink where graduate education was. You immediately, and we were already running into and hearing from people, this potential collision from students earning undergraduate degrees that maybe looked more like MPH degrees than they should, now coming into MPH degrees and saying, well, I've done all that already, and so there was a need to think through that. The whole IPE thing was happening around us. Preparation for the workforce was, of course, of interest to us, and then this whole competency movement, and then this was also at a time when the national exam was starting to gain some traction, so we needed to talk about that as well. So the task force met. They met in person 2 or 3 times a year. They occasionally met over the phone. The task force was way too big to do any real work. So we quickly started forming expert panels, and that was nice because you could have a much smaller group do a deep dive on an issue. And then because we pledged from the very beginning to operate in a spirit of transparency, everything was public, everything was on the web. Every draft, when it was ready to be reviewed, was sent out to a wide array of people. It was posted everywhere we could post it. And so if you do it that way, you don't need a very large group. You need a small group of people who can devote the time and the energy and the thought to it. We, at every ASPH meeting, and after it became ASPPH, and I mean every meeting, so at the annual meeting, at the spring board meeting, at the dean's meeting, at the associate dean's meeting, there was a discussion about this, because as you can imagine, this wasn't all a love fest. There were some concerns about these things. Early on, as I said, we had a web page. We put everything on there. Everybody who was on a task force or committee was on there. All the minutes of all the meetings were on there. Announcements of upcoming events were on there. And early on, I had a blog. And those are hard to keep up if you've ever had one. But I used to pose what I called provocative questions to try to get people to engage. Because if you just, say namby-pamby stuff, nobody cares. But if you say, hey, suppose we don't have the MPH anymore, that kind of question. And so we would get all kind of responses, which was great. We also submitted abstracts to any meeting that we thought might have an audience that we would like to hear from, to talk with. And I said, I will go anywhere anyone will invite me, and I'll host a town hall. And again, it was about the conversation. It was about getting as much input into this process as possible. So this is kind of a kind of question, but it was interesting, the kind of responses I got to this question. So what do you believe should be the essential elements of a newly designed public health education system in the United States? Okay. And interesting responses. And in the earliest town halls, this was the question I asked the group, because in the early town halls, I didn't have a whole lot to say to them because we had just started the work. So I would pose that question and get lots of interesting responses. So when I say I would go anywhere, I would go anywhere. I've been to other places since this slide was made. I'm not technically savvy enough to know how to put these little red dots on the map, but I will add the more recent ones. So there were, I think this is my 56th. So we really did go everywhere because we wanted to hear what people had to say and what they thought, because if we were going to issue suggestions for how to transform the field, people needed to be engaged and on board. So the end result was we ended up with 6 expert panels. We had the Blue Ribbon Employer Advisory Board, which I said reviewed everything that we produced. They reviewed drafts. They gave us their input. The initial interviews we did with them informed the work groups. The town halls, as I would go out, I would bring back everything I heard, every response I got on the blog, I would bring back. All of it fed in. And over time, as I would do town halls, the early town halls were very open. Later, I would say, okay, here's the undergraduate report. What do you think? Now we're going to move into this one. So it was a very fluid process, but I think it was a very open and very fair process. So what I want to do now is sort of, okay, so that's just sort of how it happened. But now I want to, as I said, look at it through a different lens. So I told you what was going on when we started. Okay? There was a lot of stuff happening. But another thing was going on in the world around us while we were doing this work. And that was this sort of emergence of the use of a term that we thought was synonymous with public health, that people were not using synonymously with public health, and it unnerved us all. Okay? Now, people go back to 2003, this particular article in AJPH, where they sort of define population health. They very purposefully, I assume, because I don't know why else it would be in there, in the article, make a distinction between population health and public health, which sort of sets up the parameters through which we then continue this talk. Under the Affordable Care Act, all the good things we were excited about, and you focus on prevention, and you focus on population health, which we thought meant what we do. And as time went on, and those of us started engaging with our colleagues out in the changing world, and we would say, wait a minute, they're not using this term like we're using this term. Well, that's not a bad thing, because this is how people react to change. Okay? So you start with the shock and denial. How dare they use that term? And you all were in these meetings. I'm not the only one that was in these meetings saying that's terrible and they can't be saying that and they don't mean it that way and they're taking our word and they're co-opting our word. But then you move through the change cycle and you begin to realize that maybe there's a different way to think about this, and it doesn't have to be a who's using the word in the way they're using the word, but how can we use the word collectively to maybe create change. So with that in mind, I want to sort of review that history again, but through this new lens. Because if population health is now a new concept and a new context for how we're going to do our work in light of all these things that are changing around us, what did we do that could maybe lend itself to that new view? And I actually had fun as I thought about this and went back, because I think we actually were talking about this all along without even knowing that that's what we were talking about. So yes, I am revising history here. I'm gonna own that, okay? So the undergraduate learning outcomes, remember I told you that was where this sort of began, because we had done this work, and now for this you have to go back even a few more years. Obama had just been elected. He was giving one of his first speeches about health and healthcare. A group of us were holed up at the O'Hare Hilton in Chicago, which is a lovely place to be. And we were there because ASPH was asking itself the question, should we care about undergraduate public health? And you can't make this stuff up, okay? And because if you remember back in 7, 8, 9, these programs were appearing, right? These undergraduate public health programs were appearing, and you didn't necessarily know it, though a couple of us had college-age kids or college prep-age kids, and you'd go on these college tours, and I was always told to stay in the back of the room and not say anything. And so you'd just kind of sniff around, and I'd be like, I'm smelling public health. And you'd start, and I talked to college, I said, yeah, I was smelling public health too. And then you start looking, and there's all this undergraduate stuff going on. AAC&U had already been partnering with APTR, the public health program and others group. They had already been in this space. If you've ever seen the intro to public health, intro to EPI, they developed Curricula. That they had jumped on this before ASPH really even gave this much thought. So we were holed up at the O'Hare Hilton deciding whether or not ASPH should care about this. And we heard the president, we were so inspired, and we said, yes, we must care about this because this could be our future. And we got really excited about not undergraduate degrees, but about what would the world look like if every undergraduate could be exposed to public health? What would the world look like? And that followed the IOM, had issued a report saying that everyone in the population should understand public health. All med students should understand this. So this all sort of fit. And so I would argue that without even knowing we were doing this, back in 09, 08, 09, whenever it was, we actually were developing a population health learning model. And I bold population because it was both learning about population health, but it was having a population learn about population health, right? Because if you think about it, if you really could reach every undergraduate in the country, I just want you to contemplate that. And we got really energized about that, and that's why we developed that model. And the model was built around the LEAP framework, which is AAC&U's effort to really change up undergraduate education, and the model for that. And it works along these 4 domains that students need to understand human cultures and the natural world, and then we added as they relate to personal and population health. And those were the words we used at the time, because at the time we used those words synonymously with public health, but I think it works here now in every way we think about this term. They need to develop skills, both intellectual and practical. They need to learn how to be socially responsible, and then the program needs to apply all that in some kind of way that integrates across. Now, so I said, we did that. Then, huge demand from the field. Great, you did that, but you're not helping us any. We need to know how to design these degrees. So we said, okay, big challenge early on. There was a lot of angst about what were you developing these undergraduate degrees for, because if they're pre-professional degrees, I don't want ASPH to have anything to do with them, because that's what we do at the graduate level. If it's just a liberal arts degree, then that might be fine, because that's not a threat. And we decided early on, we didn't care. As ASPH, we didn't think the universities were asking us that question. They were asking us, what should the content be? What should it look like? How would it help students? And so we said, hey, not our call. Universities are going to do what they're going to do, and students are going to do what they're going to do. If they're going to get jobs, great. If they're going to go on and get MPHs, maybe we should be concerned about that in a good way to make sure that there's a continuum. If they're going to go on other professional degrees, that's fine. You may be familiar with the degree at Hopkins. Hopkins has had an undergraduate public health degree for years and years and years. It is the most popular undergraduate program on that campus, and it, over time, became the pre-med degree. So there's room for this, right? It's not a closed door. So, and again, I'm providing this exactly as we thought about it. So when you're in the undergraduate world, you have to think about, the background stuff, the courses that they take that are common, and then we had the public health domains, and you see population health challenge. You see the word in here. We weren't thinking about it that way, but again, if you look at it through this new lens, you say, whoa, yeah, it would be important for undergraduates studying public health to understand the different ways people think about this term and how it's being applied and the opportunities that it presents for them. So I think it's really, really cool. We also said that they needed to have skills, professional skills, and we talk about critical thinking and system thinking and leadership and teamwork. And again, all those skills are very, very important for all of us as we learn new ways to work with our clinical partners and UACOs and CINs and all of these things. I call this undergraduate. When you get in the 4-year world, you immediately find yourself in the 2-year world, which was a surprise to a lot of us who've not been in the undergraduate world. You probably know this. I think it's 48% of students who earn an undergraduate degree in this country start in a 2-year college. So that's a huge opportunity for us. It's a huge pipeline opportunity, and it's where a lot of the sort of entry-level health workforce gets trained. So all those techs and assistants and aides come out of the 2-year colleges. So even just infusing some public health content there helps them be better participants in this whole population health thing. So we got very, we got encouraged about this. We looked at the pipeline issue. We looked at the opportunity, just like in the Learning Outcomes Project, to put public health content into your colleges. We got excited about the possibility of 2+2, where they get a 2-year degree and then move into our programs, and we're seeing more and more of these partnerships now being formed. And the group that did the work, the expert panel, got excited about actual terminal 2-year degrees. They called it I can't talk today. I've been too busy. A coach, there are these programs now being formed. So they actually came up with curricula for 2+2 transfer degrees, and they worked with all the professional groups that do this work, and they came up with a curriculum for a terminal AS program, which is neat. Now the MPH was the big bear in the room, and a big challenge, and we went around and around. We actually did suggest not having it anymore. That was a task force discussion. Actually, Bob Meenan, your friend, started singing, "Imagine there's no masters. It's easy if you try." And we actually went down that path to see what the world would look like. If you had all these growing undergraduate programs, if the other health professions were moving to the doctoral level, DPT, DOT, DNP, PharmD, right? Maybe we should do the same. And we had a long discussion about that. And in the end of the day, we decided we weren't ready for that, and we went back and reread Welsh Rose and said there's still a need for an MPH. So we said, all right, since we've agreed to that, we need to dive in. And we need to actually say, and we had to say this out loud, we do need to reconsider the rationale for this degree and the design of this degree for the future. We had to say that. We had to get people to agree that that was true. That was a conversation worth having. And of course, one of those needs and opportunities is this growing understanding, different understanding of this particular term. And again, the population health term shows up prominently, though again, I don't think we were thinking of it in the current way. I think we were thinking of it in the old way, but it's there, so it provides the platform. So you all know this because you've been redoing your core. The five silos or no more. We wanted applied and integrated, and you'll notice that looks just like the LEAP framework from AAC&U because all of this was an iterative process. We learned each step, and that we would have concentrations, and employers like this. They said, yes, we want people with a clearly identifiable skill set that can work in our world, but also that those same critical thinking, systems thinking, professionalism skills that came in the undergraduate apply here as well because we want these students to be able to adapt to a changing world. Now, you can't read this at all, and I don't intend you to read it. What I'm showing you, though, is that there was this incredible confluence of thought from not only our group, the expert panel on the MPH, but the employers, what the employers said they thought the critical skills were, what they thought the foundational skills should be, what the practice council, they had been developing a revised set of competencies, what they believed, and then the NBPHE, the board that administers the CPH exam, had just completed a job task analysis where they actually surveyed thousands of people working in public health and asked them, what do you do every day? And the same themes emerged. So all of these things that you see in the curricula that is suggested in the expert panel, we did it independently, as did all these other groups, but there's an amazing confluence. And then the one on the left that's bolded are at the time, the draft set of skills that CEF had put out there, which are pretty much the same. They've been tweaking them with advice from the field. But just to show you that there's this confluence here, which I think means that we can kind of lay that to rest and move into some of these new topics that are so important. So as I mentioned earlier, there was still this ongoing tension between what is a DRPH really? Is it really different from a PhD? And the group that worked on this said very assertively, yes it is, and it needs to be, and stop it. It is the Advanced Leadership and Practice degree, and we're sorry if in your institution you're not allowed to have one, or you aren't allowed to have a PhD, which is the real problem. There are schools that are very upset. They can only have a DRPH. They want it to be their research degree. They want it to be like a PhD. And we just kind of said, you know what, we just have to, that's fine, and you'll work it out in time. We're not, but this, we just have to be clear. And again, it's very, very clear in the document, and now this is a little later, emphasizing population health approaches. And if you think about a DRPH, Advanced Leadership and Practice means across the board. And I think the programs that are either developing these anew or rethinking them are thinking along that. It's not just traditional public health sector, it's the private sector, it's the nonprofit sector, it's the military, it's all these places where these people can be, and they have to be able to maneuver through all the different ways we are now thinking about this particular topic. IPE, again, this was going on. The task force said, yes, we have to address this. IPE to us is more than just high-quality team-based care, though that's very, very important, and we think everyone should be trained to provide high-quality team-based care. The initial competencies did say population health, and that was hard-fought and hard-won. The two public health people on that panel had to fight to get that in there, but it's there. So again, it's there. It's a placeholder. And we actually now have an opportunity because they're revising those competencies, and we've been able to weigh in and try to add the population health lens the way we're talking about it here. And so in the task force, we also talked about, like the undergraduate learning outcomes, what would the world look like if we taught everybody who interacts in any way with a community that affects population health, if they understood this? What might that look like? And we actually went down the path at that particular meeting to say, well, suppose we didn't have schools of public health at all, and we just taught public health extremely well in all the other programs. And then again, we said, well, who would do that if we don't have schools? You're not training anybody to do all that teaching. So we came back. These meetings were a lot of going way out there and pulling way, way back. And so the fifth expert panel, titled Population Health Among All Professions, again, later in the process, where we're now having these conversations about what in the world does population health mean, and really thinking about it in the context of our conversations with our clinical partners, but also all of the other professions that potentially affect the health of the public, either in a positive way or not. So urban planners and architects and people that run businesses and all of that. And that group quickly discovered, when they started making phone calls and interviewing people, that yes, they were happy to talk about what we thought should be in their curricula, but they also wanted to talk about what they thought should be in ours. So if public health professionals are going to be effective leaders interacting across communities, public, private, nonprofit, they need to understand what all of these other professions do. So that's a very rich report. If you haven't seen it yet, there's a lot in there. And then, of course, the last panel was the workforce said, and these are our practice partners in state and the traditional public, but they called and said, we'd hate this process to end without us at least having a stake in the ground that says we care about this. And so they looked, and again, this was the very last panel, so they looked at everything we had done, sort of culled the best of everything that was done, and just basically said, look, we need this kind of ongoing training for folks that are already in the profession, those that have earned public health degrees and need continuing professional development, and those that have not. Because the survey that ASTHO just did, again, reveals, I think 16 or 17% of the public health workforce, only 16 or 17% of the public health workforce has a public health degree still. So there's a lot of people out there doing public health work that need us to think about, at least, their training needs. And again, beyond that workforce, and the group didn't expand because we just didn't have time, but we talked about, what's the responsibility of schools and programs of public health to the greater workforce doing population health the way they think about population health? What opportunity is there for us to provide the kind of education and training and professional development to those groups, while we're also trying to meet the needs of our sort of core partners? So we framed the future. If you remember, the logo was just a frame. Now we're bursting out of the frame. That was pretty cool. I'm not a design person, but I kind of like that. So now we're bursting out of the frame, and it's now up to everybody else. So we concluded that part of the work in March of 2015, so almost more than a year ago now. And we didn't issue a report. As we said at the beginning, we're not writing a report. This isn't about a report. This is about the conversation and how we get people thinking in new ways. And as I've just shown you, I hope you agree with me, things were already changing when we started. They've continued to change while the work went on, and they're going to continue to change as we move ahead. So, having just come back from the annual meeting of ASPPH, we talked a lot about population health. It was a major focus of the meeting because it is what the future is about in some ways, you could argue. The new criteria, and I have to tell you because I'm on the council and I'm not supposed to tell stories from the council, but we had this very interesting conversation about this very idea. Is population health just another term for public health? And if you have to understand, the CEF Council is academics and some practitioners and some lay people. That's what the Department of Education requires. And staff who may or may not, they're very busy, they're very detail-oriented, they might not be out here. And there were people in the room who literally didn't know what we were talking about. What do you mean there's another use of the term population health? And we had to spend quite a bit of the day and going online and finding things. We're not making this up. Many different groups are using this term in very different ways. There's not one way because they look at it differently. Depending on how they view their responsibilities, we view it as everybody. A health insurance plan might view it as who they enroll. A hospital might view it as who's in their beds. A managed care or a ACO might view it as the patients that they serve. Everybody's viewing it in different ways. They're beginning to get an idea that however they define that population, they're beginning to get an idea that they have to do more than the sort of acute clinical care they used to do. they're still trying to figure that out, and they haven't figured out that ultimately we all have to be concerned about the population, the way we think. This is a moving target. But now in the criteria, it absolutely reflects both understandings of the term. So that's been a huge change. Again, as we see undergraduate majors grow, we're seeing degrees grow across the country, we're seeing more minors. I was just talking with some folks here about getting public health in the gen ed curricula, which is the curricula that all undergrads take. Getting it in the two-year college, we have opportunities to help people understand these concepts and think about how they can contribute. The way we are redesigning MPH core curricula provides the same opportunity, and a truly population health approach to interprofessional education, recognizing how they're using the term and not being angry at them for it or not being dismissive of it, really does open all doors. This gives us an opportunity to have these kinds of conversations that we've been wanting to have all along. So as I said, the major focus for ASPPH, beyond the very scary discussions we had about presidential transition planning, which I'm sorry that we had those at all, I should please let's talk more about population health because I don't want to talk about that. But this is their major item, is this. And I have to tell you, the conversations have been fascinating, absolutely fascinating. I heard some of my fellow deans say, I don't know if you heard this, we aren't doing that. We aren't going to do any of that. And that's sort of, I don't even know what to say to that. You can't say that. I mean, you can because they just did. But and other people that are sort of way out there and other people that are somewhere in between, still frustrated, still not sure how. But I think if we go back and look at all the work the Framing the Future Task Force did, all of those discussions, all of those reports, it's in there. The opportunity is in there. This isn't something new we have to layer on. It's not yet another thing. But it's in everything we have already said. And I think it gives us the platform to shift the perspective, the spirit of what's the future. If we really believe that this is one critical opportunity for the future, we can embrace it within everything that we have already done. Back to the Kindig and Stoddard report. This is my favorite quote in the article. No one in the public or private sectors currently has responsibility for overall health improvement. Every time I read that, I am shocked to the core of my being. I mean, this has been my entire career. I thought that in every state in these United States of America, there was a state health authority who was responsible for overall health improvement. But I think they're making a really important point, because what authority does that person really have over all of the elements of this complex and growing more complex health system, healthcare system, however you want to talk about it. So I think we do have an opportunity as public health leaders in the academy to really be that space, that sort of safe, neutral space where we can bring people together and have these conversations. We can infuse it into our teaching. We can create the next generation of public health practitioners and professionals that understand how to maneuver through this and understand that it's not enough to look at the social determinants of health. It's not enough to look at a life course perspective. It's not enough we also have to be thinking about a true health system that embraces where the health care system is and where it's going to go. So I put this change cycle chart up here again just to say it is ours to frame. The future is ours. This has always been about the conversation. And I guess I'm sort of surprised that I still hear some of my colleagues in the shock and denial phase. But we can't be in shock and denial. We have to be moving far more toward acceptance and really embracing this term, not arguing about who it belongs to, but actually embracing and preparing and promoting the future professionals who will help us improve the health. And with that, I am done. And I will take any question on anything I said or didn't say. Yes, Dean.
First of all, thank you very much. This was extraordinarily helpful. What are your thoughts about, what are your thoughts about the undergraduate? What are your thoughts about the undergraduate degree being a liberal arts style degree where it helps people think about what I would call population health, and we can have the population health, public health discussion separately, versus it being a pre-professional degree? what are your thoughts about pros and cons? And I know different schools do it differently, so I'm just wondering whether or not you have done the sort of formal thinking about evaluating strengths and weaknesses of both approaches.
So, being completely honest, coming at this from where we started with the learning outcomes, I'm much more on the liberal arts side of the house, because I think there's a huge opportunity there. The AAC&U LEAP framework sort of helped, I think, create the interest in public health, because if you look at that framework, knowledge of human culture in the physical, natural world, intellectual and practical skills, personal and social responsibility in an integrative and applied manner, public health is the perfect way to do that. It's the perfect way to align curricula. And so it's not surprising, when I got into that world, it wasn't surprising to me that public health had emerged as it did. And I should have said this if I didn't. I mean, I kind of alluded to it, but these degrees were not emerging in our schools and our programs. They were emerging in the liberal arts colleges across the nation out of biology departments, English departments, math departments. They were emerging in sort of inexplicable places. And there was a hunger on the students' part to have that kind of opportunity, to think about all the things they were learning and do something with it, right? So actually integrate it and apply it. And we were tracking for a while people using the learning outcomes and how they were applying them and how they were integrating them. And every year at meetings, at the AACU meeting, we would hear, and it was just extraordinary how creative and clever people had been. And those students in that kind of educational experience were also going and getting jobs. So there are people, and I have colleagues that will argue that where they are, there's a huge demand, a huge market. They are absolutely preparing these students for entry-level jobs in the workforce, and that's fine, if that makes sense to you. But I still would argue that there's something about taking a liberal arts approach where you read the literature and think about what it says about public health, where you do science, a normal science class, but you're doing an experiment on a public health topic. There's something about that that just feels more intellectually rich to me, as opposed to, okay, here's what you're going to do if you're inspecting restaurants in here. That feels more trade schoolish to me. So I'm not saying one's better. I think you have to know your market, but I kind of feel sorry for programs that skip that step, if you will, that sort of didn't give themselves the opportunity to create that kind of degree. And that's very much my personal opinion. We argued a lot about this on the task force.
I had a question based on an article I read after the Framing the Future came out that was critical. It was from someone at Tufts, and I can't remember his name. But he was responding
Dr.
to the fact that...
My friend Tony Schlaff.
Yes. He was talking about the fact that one of the ways of presenting how the courses sequence is that your fundamental or your core courses transmit knowledge, and then it's in the higher level courses that you actually learn to apply. And he was arguing that from the very beginning, you don't learn unless you're applying, that whole idea of active learning needs to be all the way through the curriculum. Can you speak to that?
Sure, and we actually wrote a response to Tony. It's in there somewhere. Tony's a good friend. He was on the task force. I don't think we were as strongly arguing that you had to have not pure knowledge and then apply skills later as he perceived. So that's the first comment. And he and I have had lots of conversations about this. And the other thing I would say is just an overall overarching statement is these were recommendations developed by, as I said, small groups of people who were passionate about the issue and devoted their best thinking at a point in time. And they were reviewed widely, and the best thinking at that point in time, and that's all it is. And so even today, we're not thinking about those things in the same way that we did then. SEAF, if you're lying awake at night and reading criteria, has absolutely embraced, and again, it goes back to the undergraduate learning outcomes in the LEAP model, this notion that you should have experiential learning embedded throughout. That's very much in the criteria. If you haven't noticed it yet, I know Lisa and others I'm sure have. Because we heard from Tony and from others, and again, I don't think the task force ever really meant to say that there should be that clear cut of a break. And how we all do this ourselves, how we all frame our own futures is going to vary based on our circumstances and where we are. and that's okay too. One of the things that we're talking about is how we go back and sort of assess what the effect was of all of this and who has changed and how has that happened, and we're trying to figure out a way to go back. I'm trying to figure out a way to go back and contact everybody that I spoke to and said, so what has happened? Maybe some kind of qualitative assessment. But yeah, I don't think he perceived the situation correctly, but he's not wrong in what he suggests. And I think you see it now. There is more of a push to. And actually, I don't think I'm looking at Lisa. I don't think the MPH panel didn't go so far as to say there shouldn't be a field placement. But CEF has. CEF has said, for a lot of reasons, which I won't bore you with, that we want experiential learning, and we want a deep experiential learning. But this notion of a prescribed field placement really hasn't worked well for everybody. Works for some, but not for all. Someone in the back.
All right, so my question is, so on the slide you mentioned that even for all medical students, you have all the 18 hours of stuff as well. I'm just curious about how you would enforce that in a way that, because I know at least from few stories I heard that it's a doctor that these public health and they're not really passing this issue. They have this kind of idea where like they're teaching and they've got a technical left kind of thing, but they're not really teaching public health. Do you kind of suggest that he as a public health, I guess, for kind of lead the charge in the way that we supposed to medicine, or do you envision another way?
Storm the medical school classrooms. I think what the IOM was suggesting, they believe every medical student should know public health, and they meant that, and no one can enforce that. I think it's a huge opportunity for schools of public health and for programs of public health, but it's got to be a partnership, and there has to be a shared idea of what it is you're trying to accomplish. I think a lot of medical schools, I think they teach sort of basic biostat and epi because they're teaching research methods and how to read the literature and how to understand all that, because that's very, very important. But are they really teaching population health the way we mean it? Are they teaching the social determinants of health the way we would teach it? Just released a week or so ago an IOM report on how to educate health professionals on the social determinants of health for the 21st century. There's a little theme going on here. So there is an attempt to try to reframe what that might look like. And I think we're in good positions if we choose to take those positions to offer to partner, to provide learning opportunities for students in all the clinical professions, and the task force would argue any profession that affects health. I think sometimes students learn best from other students. So I know a lot of us have been trying to use the whole interprofessional education idea, not to say, well, we're going to put you all in a classroom and you can parallel play for an hour, but to give you situations that you can work on and discuss together. And so I think that there's a lot of opportunity there, and I think students can help us think through that, but it's something that we could do if we choose. We don't have to. I could tell you my favorite story about the University of Miami. You want to hear it? So University of Miami, you got to tell me yes, because I'm standing up here. At the Miami School of Medicine, they admit 200 medical students each year. Their cohort, 200 cohorts, big medical school. And a couple of guys have been there forever, and they've had in a folder their dream of a truly integrated MD MPH. They've kept it in a drawer for years. Finally had a new dean who said, you know what we ought to think about? A truly integrated joint MD MPH. And they said, oh, well, funny, you should mention that. And they pulled out the dusty file, and they changed, this is the key. They decided to start with 50 students, and they changed the medical school curricula to accommodate the public health curriculum. That never happens. For those 50 students, they admitted their class of 200. They put out the call, and they said, we're going to offer this opportunity, and they probably had to buy their books or something to get them to sign up. But they got 50. And the next year, they had way more than 50 of the accepted 200 want to do it, and way more the third year, way more the fifth year. As time went on, the students not in the curriculum would say, well, how come we don't get to do that? Why aren't we learning to be the navigators for the CMS Affordable Care Act sign-up? Why aren't we working, volunteering at the homeless clinic? Why aren't we? But they didn't want to do anything because they wanted that first cohort to go through. They wanted to see if they were successful, i.e., did they match? Every one of them, they just finished the 4th year, okay? They all matched very successfully. They're in great institutions. Everything's fine. They've now, I think they're going to let 100 in now. But their goal, he said to me the other day, we're starting to wonder now about the students that we admit that don't want to be in the dual MD MPH. We're wondering why we want them here at all. So their goal, see, I hate this, they're right down the road from me, they're killing me. My goal, they said, our goal is to have, if you go to the School of Medicine at the University of Miami, you get an MD MPH. That's what they're working toward. That's a beacon on the hill that we can all learn from. Now, we all don't have to do that, but what are they doing and what opportunities are they seizing to create that kind of learning?
Please join me in thanking Dr. Petersen.
Thank you, Deborah.